Welcome to today's Focus on Aging Federal Partners webinar. This webinar series is sponsored by the Administration for Community Living, the Centers for Disease Control and Prevention, the Health Resources and Services Administration, and the National Institutes on Aging. My name is Erin Long. I lead the ACL's Alzheimer's and Dementia, Alzheimer's Disease Programs Initiative, and I'll be your moderator today. I would like to thank all of the Focus on Aging partners for their efforts in bringing this webinar and our esteemed panel to you today. The topic of today's webinar is end-of-life care. Care at the end of life can be incredibly complex, among other things, supporting physical, emotional, spiritual, as well as practical needs. It can be particularly challenging for people living with dementia and their caregivers. Next slide. You can see from the presentation titles below on this slide that our expert presenters today will delve deeply into the several complexities of end-of-life dementia care. Next slide. I'm pleased to introduce today's speakers, starting with Dr. Susan Mitchell. Dr. Mitchell is a professor of medicine at Harvard Medical School and a senior scientist at the Hinda and Arthur Marcus Institute for Aging Research at Hebrew Senior Life in Boston, where she directs the Palliative Care in Aging Research Center and co-directs the Interventional Studies in Aging Center. She's a geriatrician and health services researcher. Her research focuses on improving outcomes for older patients with advanced illness, particularly those with dementia. The title of her presentation is Evidence and Goal-Based Decision-Making in Dementia at the End of Life. Our next presenter is Dr. Maisha T Robinson. Dr. Robinson is an assistant professor in the Department of Neurology at Mayo Clinic in Florida with a joint appointment at the Department of Medicine. Upon joining the staff of Mayo Clinic, she established the clinic's first neuropalliative care program and currently serves as the division chair for palliative medicine, as well as the program director for the Hospice and Palliative Medicine Fellowship, and as the chair of the ethics subcommittee. The title of her presentation is Maximizing Quality of Life in Dementia, a Palliative Approach. Our next speaker will be Dr. Mary Beth Gallagher. Dr. Gallagher is a board-certified psychiatric nurse practitioner with a doctoral degree in nursing. She serves as director of hospice at Hospice of the Valley's Dementia Program. Her commitment to improving dementia care was initially inspired by her own experience as a family caregiver, sharing the journey with her loved one with dementia from diagnosis to death. The title of her presentation is Palliative Care for Dementia in Action, a Real-World Case. Our fourth speaker will be Dr. Joan Carpenter. Dr. Carpenter is an assistant professor at the University of Maryland School of Nursing, a health scientist at the U.S. Department of Veterans Affairs, and geriatric and advanced certified hospice, and a palliative nurse practitioner. Educated and trained as an advanced practice nurse and scientist, she has over 20 years of experience working with people living with serious and complex illness in post-acute and long-term care settings. Dr. Carpenter collaborates with VA and community nursing homes and interdisciplinary health professionals to implement evidence-based practices, test complex interventions, and conduct real-world studies that support high-quality palliative care. The title of her presentation is Partnering Staff and Families to Enhance Advanced Care Planning for VA Community Living Center Residents with Dementia. Our fifth and final presenter will be Dr. J Neal Henderson. Dr. Henderson is a professor emeritus of medical anthropology at the University of Minnesota Medical School, Duluth campus. He is the contributor to the Alzheimer's Association and CDC's Healthy Brain Initiatives Roadmap for Indian Country, and the principal author of The Savvy Caregiver for Indian Country. He is Oklahoma Choctaw. The title of his presentation is Walking On, Indigenous Perspectives on End of Life. Next slide, please. So just a quick housekeeping note, if you want to, if you have any questions during the webinar presentations, please feel free to scroll down to the bottom of the page and submit live feedback where you can type in your question. And with that, we will turn to Dr. Mitchell to hear her presentation. Thank you.
Thanks very much. Great to be here. Next slide, please. Next slide. So the objectives of my talk will to better understand the clinical course of advanced dementia and gain knowledge about the most common complications, and then to operationalize goal-based approach to decision-making. And all of this will be informed by the best evidence. Next slide, please. To make sure we're on the same page, I'll just give a description of what I mean with advanced dementia and where most of this evidence comes from in a patient with global deterioration stage 7. That's the stage 7. They no longer have such profound memory deficits. They no longer recognize their family. Their verbal abilities are limited to less than 5 words. They're bedbound or non-ambulatory and incontinent of urine and stool. So while most of the evidence in this talk applies to a patient like this, certainly many of the principles may be applied more upstream, but this is the patient that I'll be mostly talking about. Next slide, please. The Cascade study, which was published over a decade ago now, provided a fairly good description of what happens at the end stage of dementia and followed 323 nursing home residents with global deterioration stage 7 for 18 months. The main findings were a mortality rate of 55%, similar to that of breast cancer, metastatic breast cancer. And the most common complications experienced by the cohort included eating problems, of which 90% experienced. And the next most common were recurrent infections and fever that occurred about 50% of patients. Of note, other sentinel or potentially lethal events like strokes, fractures, myocardial infarctions were exceedingly rare. In fact, among the 155 decedents, only 7 of them experienced one of these other events. And so you can conclude that these patients really died from their dementia and not these other things, albeit many had infections in the last 2 weeks of life, just like in metastatic cancer. I'm sure you would agree that even if they got a pneumonia in the last 2 weeks of life, they still would have said they died of cancer, similarly with dementia. And the other main piece came out of the Cascade study that showed that we interviewed families every 2 months along the way, and we found an association between families who understood that the prognosis of their loved one was limited and who also felt they understood the complications they were experiencing. Those residents got less aggressive care. So it was very important what the family members understand in terms of what the patient experienced. Next slide, please. We asked family members in the Cascade study what decisions they made every 2 months. And here you could see that eating problems affected were the source of about 30% of these decisions. And then the next most common were infections, about 25% of decisions, very much mirroring the clinical complications we saw in the patients. So this is simple but important information. You can tell families that as your loved one enters the final stage of dementia, you may well face decisions relating to both eating problems and infections. Next slide. So I'm going to focus on those 2 things as we move forward. Dementia is a disease with a very long course. We now have a good sense of what happens at the end stage. So advanced care planning is absolutely critical, with an opportunity really to discuss early, either with the patient or with their loved one, what they would want in terms of their care in the later stages. And even if they can't make decisions more upstream, at least they would have understood and have some warning that these are some of the decisions they might face, and that will set the stage for future discussions. Next slide. So steps for decision-making will operationalize for eating and infections involve the following steps, which I'll go through in detail for each. Clarify the clinical situation, determine the primary goal of care, present treatment options, and then weigh options against the patient's perceived values and preferences. Next slide. So in terms of eating problems, I think it's important for the families and patients to understand that once eating problems develop, most often these patients are near the end of life. And when people understand that this is a hallmark of the end stage of the disease, they might be more ready to opt for comfort care. Next slide. I've asked over probably 1,500 family members now in my various studies of patients with dementia what the primary goal of care is, and about 62% will say comfort is the goal of care, meaning that all treatment should be geared towards comfort, even if that means declining potential invasive interventions that may prolong life. Only on the other extreme, only 7% say life prolongation is still a goal, even if that means uncomfortable, aggressive interventions, and about a third fall in the middle with the goal intermediate, and that kind of means if there's a conservative treatment, maybe like an oral antibiotic that can get the person back to where they were before the acute event, that would be okay. Next slide. So I try to get family members somewhere on that trajectory of goals of care, and here you see depicted some options for feeding problems. Hand feeding continued to the extent it's comfortable to the patient versus tube feeding. Next slide. Over 15 years now of research shows that no demonstrable benefits of tube feeding in advanced dementia, albeit there's no been randomized controlled trial. Most of these feeding tubes are placed during acute hospitalization, whereby the patient or nursing home resident has been sent in for some other problem, most often a pneumonia or suspected aspiration, and during the busy hospitalization, a feeding tube is put in. So even though someone might think they might prevent aspiration, etc., again, a Cochrane review of all the evidence has shown that it has no demonstrable benefits. It does not prevent aspiration, healing of malnutrition or healing of pressure ulcers, does not prolong survival that we can demonstrate. And even though families may be worried about hunger and thirst, as best we can tell from studies of cancer patients near the end of life and some caregiver reported studies, the tube-fed patients do not appear to be more comfortable. Next slide. And these are just the survival curves from 2 studies comparing survivals of patients with and without feeding tubes with advanced dementia. And you could see the curves are superimposable with no survival benefit detected. Next slide. There's certainly risk, although putting in the tube is safe. There are special situations to consider. For example, these patients get agitated, and if they try to pull out their tube, this might necessitate chemical or worse physical restraints. There's a lot of hospital transfers or blockages and dislodgements of the tubes, which can be particularly traumatic for patients. And I mentioned there's no, the feeding tube-fed patients might in fact have increased risk of poor healing of pressure ulcers. Next slide. So putting it all together to align with goals of care, if comfort was goal of care, you certainly would go with hand feeding. Prolonging life, we have no randomized controlled trial. At the same time, we have no evidence from cohort studies that tube feeding prolongs life in advanced dementia. Next slide. Putting it all together, there's been a lot of expert opinion as well as multiple position statements by leading organizations that tube feeding has no demonstrable benefits and indeed should not be offered in advanced dementia. Next slide. This just shows the incidence of feeding tube insertions in advanced dementia from 2000 to 2014, showing that, in fact, the insertion rate of feeding tubes in this cohort has declined by about 50% over that time, so that's the good news. Next slide. The bad news is this is a similar slide, except at a different scale on the y-axis. The top slide is blacks, and the bottom line in purple is whites. And you can see there's been a decline in both blacks and whites, but both in 2000 and way back in, and even in 2014, there's still a lot more feeding tubes getting put into Black Americans than white Americans. And of course, the underlying causes of this is fairly complex, but we still have a ways to go for reducing these disparities. Next slide. In terms of infections, next slide. They're very common at the end stage, a high mortality rate and discomfort associated with symptoms, workup, as well as treatment. Next slide. Again, you try to get the family members or patients on the somewhere on the trajectory of articulating what their goal of care is. Next slide. And then talk about the treatment options with reference to those goals of care. Next slide. And here you see comfort care versus obviously giving antibiotics. There's a lot of antibiotics given to patients with advanced dementia. Data from the Cascade study shown here that in the last 14 days of life, that's the last bar, close to 40 2% of all decedents had got antibiotics just before they died. Next slide. At the same time, nursing home residents with advanced dementia are 3 times more likely than other residents to harbor antimicrobial resistant bacteria that they bring into hospitals and spread to other patients. So giving antibiotics at the end of life certainly has both public health and individual burden issues. Next slide. In the SPREAD study, where we followed patients with advanced dementia and recorded those with suspected infections, and here you can see LRIs as lower respiratory tract and UTIs as urinary tract infections suspected. And the number of episodes we saw, about 3/4 were treated with antibiotics, but in the last line, you could see only 34% of those treated LRIs actually met criteria for suspected bacterial infections, and only 19% of treated UTIs met criteria for suspected that warranted antibiotics. So it's a lot of antibiotics that are given inappropriately. Next slide. And in the SPREAD study, if you started without a drug-resistant organism, you had a 40% chance of getting one at the end. And the most common risk factor, of course, was getting antibiotics. Next slide. We did compare survival in patients with who got antibiotics and did not get antibiotics. There just seemed to be a survival benefit of a few months getting antibiotics, but the survival benefit with antibiotics doesn't appear to be different whether it's given with oral, IV, or IM antibiotics. Next slide. Same is not true for, I'm going to skip this slide. Next slide. For UTIs, there doesn't seem to be any benefit at all in suspected UTIs for giving antibiotics. In fact, those who get antibiotics tend to do worse even after adjusting for whatever you can. So next slide. I'm going to skip this. Next slide. So aligning with goals of care, if comfort's the goal for infections, you go with palliation only. If prolongation of life is still the goal of care, I'll be finished in a minute. If prolongation is still the goal for pneumonia, it probably makes sense if a few months of life is important, but there might be some discomfort associated with that. And for suspected infections, there probably is no survival benefit. Next slide. So in summary, dementia is a terminal illness. Feeding problems and infection are the most common complications and decisions. And aggressive interventions are less likely when families have an understanding of the poor prognosis and expected complications. Next slide. Ethical decision making is informed and guided by goals of care. We know that tube feeding has no demonstrable benefits and, in my view, should not be offered. For suspected infections, there's gross antimicrobial overuse. And as I mentioned, for pneumonia, may prolong life by a few months, but also at the cause of more discomfort. And for suspected UTIs, there doesn't appear to be any survival benefit. Next slide. And finally, take-home points of tremendous opportunity for advanced care planning. Try to focus on the goals of care, but don't feel compelled to offer anything. If families ask about their choices, be knowledgeable about the best evidence. And make use of decision support tools such as one-pagers from the Alzheimer's Association, et cetera, as well as geriatric consults and palliative care teams that can help you as you guide families through these decisions. Thank you. That's the last slide. Thanks very much.
Thank you, Dr. Mitchell. Our next presenter is Dr. Maisha Robinson. We look forward to hearing from you, Dr. Robinson.
So, I hear it all the time. People say, I almost asked for palliative care for my mother, but I didn't want her to think that I knew something that she didn't know. Or I heard somebody say, Dr. Robinson, I almost asked you to see my patient, but I didn't want him to think that I thought he was dying. So I want to spend a little bit of time talking about maximizing quality of life in dementia, a palliative approach. So when I think about palliative medicine, I think about a subspecialty that aims to really recognize, prevent, and alleviate suffering of all forms, physical, psychological, spiritual. And we think about not only a whole person approach, but really a whole family and caregiver approach to care. So not only are we thinking about symptom management or advanced care planning, we're also thinking about how the condition is affecting people's finances. We're thinking about coordination and follow-up. We're thinking about nutrition as well. And I say to people that palliative care is really appropriate at any age and at any stage, independent of what the goal is, whether it's about maximizing quality of life or in some cases, trying to focus on curative therapy. So people used to say, hurry, 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 somebody call palliative care. My patient's about to die. What we know now is that there's a role for palliative care at the time of diagnosis. And certainly the needs increase over the course of disease. But what you'll see here is that even at the time of death, there's still a role for palliative care in bereavement services through hospice care. You know, palliative medicine is one of the fastest growing trends in medicine. And some people are a little surprised to hear that. Well, this graph shows you that in a 15-year period, in the purple, you'll see the significant increase in the number of hospitals that have a palliative care program. And in the yellow, you'll see that the percentage of hospitals with a palliative care program also significantly increased. And people wonder why. Well, number one, we're living longer. Number two, because we're living longer, people are having more chronic medical conditions, and so there's a benefit to having palliative care involved. And then number three, people are realizing that it works. And so people are recommending palliative care to family members and friends or colleagues, and they're searching palliative care programs to try to provide the best quality of life to their patients. So when I think about palliative medicine, I kind of gave you a little bit of a definition, but it's really this umbrella term. Under the umbrella for palliative care, we're all trying to figure out how do we improve quality of life. And so there's primary palliative care, which is what really all clinicians are doing, trying to maximize function, trying to keep people able to manage their activities of daily living, all the day-to-day things that we have to do for as long as they can and doing it as well as they can. Primary care doctors are doing this, nurse practitioners that are part of primary care teams, nurses are doing it. Everybody taking care of patients anywhere is focusing on some primary palliative care just by the nature of what they're doing, specifically when they're taking care of people with dementia. Then we have specialty palliative care, which is what I do. And so when we have people that have more complex issues, whether they're complex symptom needs, whether they're some family dynamics that are challenging, whether there's some difficulties with behavioral issues and coping, specialty palliative care with a team-based approach can be helpful. And then also under that umbrella is hospice care. And hospice care is palliative care, but specifically for people that have 6 months or less to live if the disease progresses in its normal fashion. So all hospice care is palliative care, but certainly not all palliative care is hospice care. What we know is that there's a shortage of specialty palliative care providers, and some literature suggests there's even an 18,000 shortfall. So therefore, we always will need other clinicians to be providing that primary palliative care. And when appropriate, people may be referred to specialty palliative medicine or to hospice care. So people wonder, what do you do when you see people for a palliative care consult? Are you kind of hugging them? Are you holding their hands? What are you doing? And I say to people, you know, we focus on 8 specific things. Number one is structure and process of care. I want to ensure that the people that I'm taking care of understand their diagnosis. We want to be starting at the same place. I also want to make sure they understand what palliative care is and also distinguishing it from hospice care, because many people think those words are interchangeable. I talk about physical aspects of care. I want to make sure that we understand what the symptoms are and how we can best optimize the management for them. Talk about social aspects of care. Yes, are you married? Do you have children? But really, who's helping you get through this? Who is your support system. We talk about psychiatric and psychological aspects of care. Yes, we ask about, are you anxious or depressed? But really, it's more about, how are you coping with everything going on? Spiritual aspects of care, we ask people, what gives you meaning? What's most important to you? Cultural aspects of care has to do with, are there specific things that we should know to take the best possible care of you? And ethical and legal aspects of care has to do with, if you can't make your own medical decisions, who would help you make them? And what kind of medical care specifically would you want if you're at the end of life? And when appropriate, we talk about care specifically at the end of life. So when I see patients with dementia and I'm meeting with them and with their caregivers, there are some disease-specific considerations that I'm focusing on. And number one is really the Advanced Directive piece. I touched on it just a second ago. We know that there's going to be a progression of a decline in cognition. So when I first see people, I want to make sure that if they can still make decisions for themselves, that we talk about who would they want to help them make medical decisions. And I ask, if you're at the end of life with an end-stage condition, a terminal condition, if you're in a persistent vegetative state, what kind of medical care would you want? I think that's the best gift that those people can give their loved ones, because the loved ones can then honor those wishes. I talk about caregiver support. I'm going to touch on that a little bit more in a second. We talk about behavioral issues and how do we compensate for some of them as well. And then we talk about living environments. Do we need additional people at the home? Is it time to consider maybe going to a different sort of residential facility, like a long-term care facility? Where are we and how are we managing things in the home environment? And then in general, I like to make sure that people understand the disease. What is dementia? What is Alzheimer's? And then what do we anticipate coming down the pipe, right? And I talk a little bit about the sort of trajectory of disease, but also some of the things that could potentially expedite the decline, like infections or falls or hospitalizations. Focus on mood and coping as well. And then this whole piece about planning, not only for medical issues, but also making sure people have thought about financial planning as well and other sorts of planning in their lives. So there are a few things that a number of us who are neurologists and also palliative care physicians have recommended should trigger these serious illness conversations. And while many of us talk about it in general every time we see people in clinic, there are some events that should make you think, maybe we should start discussing maybe living environments or care for end of life, or should we be thinking about a feeding tube and things of that nature? And we just heard a little bit about that in the previous lecture. So event-driven milestones, when people start wandering at nighttime or having frequent hospitalizations, or if there are issues about driving safety or caregiver needs are front and center. If symptoms seem to be increasing or the burden with regard to quality of life is becoming more significant, or there's a huge decline in people's ability to function or to eat, or if they have other new or old medical issues that are compounding the situation, we should be talking about this bigger picture and goals of care. So I mentioned I was going to come back to caregiver needs, and this is a big topic, as you can imagine, when I'm taking care of people who have dementia and meeting with their loved ones. We know that there's a term called caregiver burden, and most people don't like that term because they're saying it's not really a burden. This is what I want to be doing. This is my husband. This is my wife. This is my mother or father. This is my sibling, and this is what I want to be doing. But the reality of the situation is that we know that it can take a toll on the caregivers because not only are they helping with some of the day-to-day activities because of the functional decline, but there's also the cognitive decline. And this can be challenging with the repetitive questioning and with the loss of not only the person that they knew, but of the things that they thought they'd be doing together. There's a loss of the conversation they used to have as well. And so that can be challenging. And then there are financial concerns too that impact that. So when I think about the benefits of palliative medicine, palliative care certainly can improve symptom management. It definitely can reduce unnecessary, but even more importantly, unwanted hospitalizations, particularly when people are nearing end of life. It can improve patient and family satisfaction and decrease prolonged grief and post-traumatic stress disorder among family members. So in summary, palliative care is appropriate at any age and at any stage of dementia. Most palliative care is provided by primary physicians or primary medical teams or neurologists, but there are opportunities for consultative palliative care as well, particularly when there are complex symptoms or complex situations. And we know that palliative care can improve the overall care for patients and family members. So I'll tell you, Will Rogers said, "When I die, I want to die peacefully, like my grandfather did in his sleep, not screaming like the passengers in his car." And people often say, Dr. Robinson, that's what I want to happen to me. And I say to them, I don't know if I can promise all of that, but what I can promise is that we're going to help you have the best quality of life until the end of life. Thank you.
Thank you so much, Dr. Robinson. Now we're going to move on to Dr. Mary Beth Gallagher's presentation. Dr. Gallagher?
Hi, thank you very much. All right, I think I'm supposed to get the controls here. Yes. Right, and then I'm reaching down here to see if it works. Hi, so listen, taking everything that you've just heard, what I would like to do is to illustrate in a real world situation of how these practices, how these principles are put into practice. And so we're going to be talking about Lou and Rita. So there we go. So first I want to talk about Hospice of the Valley created a supportive care for dementia program back in 2013, a palliative care for dementia program, because we most often heard from our dementia caregivers who came onto hospice service, wow, I sure wish I knew then what I know now. It would have made this trajectory, this experience very different for both myself and my loved one. So we created this program in order to ideally improve the health outcomes and quality of life for persons living with dementia. And the model that we're using is most of an educational psychosocial support with a little bit of medical oversight, meaning that we're not doing the medical management, but we have to know everything about this person, because otherwise, how could we possibly provide holistic care? And the goal is always about living well. So the supportive care for dementia program, the core components that we have is that it consists of home visits and phone visits. Now, why are home visits really, really important? Because we see the individuals in the context of their environment. And that is where so much valuable information is. We also provide phone consultations by my colleague who's a geriatrician or by myself, because in this fragmented healthcare world, it's really nice if a fresh set of eyes can come in and look at this big picture to see if everything that's being done, does it truly align with this person's goals of care? We have a 24/7 phone support system that's triaged by experienced dementia nurses. Why is this important? If you've ever been a dementia caregiver, you probably know that unfortunately things don't go wrong Monday through Friday 9 to 5 when you can reach out to your PCP. Oftentimes it's like late at night, or it's the middle of the night, or it's on the weekends. And unfortunately for a caregiver who doesn't know what to do but wants the best for their person, that leaves us the default 911, which means we're bringing in, the emergency departments, possible hospitalizations that are unwanted. It's a very important component. Respite by trained volunteers, crucial for dementia caregivers who are exhausted, and which was very challenging during COVID. And fortunately, I want to say, based on our very generous grantors here, this is all coming at no charge. So let's talk about Lou and Rita. When we met them, they were married 59 years, and Lou had cared for Rita through brain surgery and 2 types of cancer. But in his very late 70s, Lou was diagnosed with Alzheimer's disease by their long-term internal medicine doctor, Dr. J. And as the years went by, lots of times dementia is managed by PCPs, and Dr. J was getting an increasing number of calls, number and intensity of calls, with Rita struggling to manage Lou, as it pertains to dementia. So he referred to our supportive care for dementia program. Here are some of the challenges. Lou was starting to demonstrate increasing episodes of confusion and resistiveness to personal care. He was starting to exhibit more verbal and physical aggression. He's 5'10", 210 pounds. Rita's this petite 84-year-old woman. He was having real significant changes in his sleep-wake cycle, which left Rita wiped out. He was having increasing falls. They were needing to call the non-emergent number of the fire department to get him up. He was leaving home and getting lost, which in the Arizona heat can be absolutely deadly. Rita herself, she had no dementia experience. She knew that he was diagnosed, but that's all she knew. And she didn't have any caregiving experience. And yet here she was in the trenches day to day. And she lacked any support, which is a real common experience for people with dementia. I mean, Arizona, because we're not from here, a lot of us. And so she didn't have any children. And the friends that were even in her local community, they were old and sick, and some of them had died. And Dr. J, who was so devoted to this couple, he just had limited time and limited dementia expertise in order to respond effectively to the needs that this couple had. So the supportive care for dementia program was called, and our dementia educator, as we call them, Amy, visited Rita and Lou in their private home and listened deeply. From their perspective, what were the most pressing needs? Indeed, we have an agenda, but we come in and we want to listen and meet the people at their pain point. She also was able to assess the living environment for safety and then to listen really closely because the behavioral expressions were driving the acuity of need, and so she was listening for safety there as well. She performed some baseline cognitive and functional assessments. Why? Well, we want to know the deficits here because we want to keep the person safe and anticipate the needs that they can no longer meet themselves. But additionally, we want to identify their residual abilities so we can celebrate them for as long as this person can do it. We collected data such as the Caregiver Burden interview, and we inquired about Rita's well-being, which is something that our system falls short of all the time. And we stressed to Rita that from this point forward, she no longer had to do this all alone. And we encouraged her, please call that 24/7 number whenever you need to. So in the assessment, what did we learn? Well, at this point, Lou was in the advanced stage of Alzheimer's, not ready for hospice, right? But still really dependent on Rita for all of his needs. He had an unsteady gait. He was incontinent bowel and bladder. He had limited verbal language, meaning he didn't understand what was being said to him, and he wasn't able to effectively communicate through words what his experience was and his needs. He required cues for all of his activities of daily living. And indeed, for this couple, there was two important things. I want to be kept safe and comfortable, and I want to remain at home. Never remove me from home. Rita completely was overwhelmed. She had no connection or support systems or resources. She lacked dementia-related knowledge. She didn't know how to navigate the resources that were available in the community or her long-term care insurance, and she absolutely refused to consider placement and in-home paid caregivers. So here's just a very small example of some of the things that we tried to provide for her. First of all, we helped provide the information like Dr. Mitchell shared with you to help Rita make collaborative, informed decisions on behalf of what Lou would have chosen for himself. So for example, in this case, he didn't want CPR, definitely wanted to be kept out of the hospitals, didn't want a feeding tube. But as far as infections, on a case-by-case basis, they were going to decide whether to or not to use antibiotics. Because behaviors were really driving the need here, we observed him for distress and taught Rita about that. Comfortable people with dementia don't exhibit behaviors, that behaviors are an expression of an unmet need. How do we maximize his comfort? And how do we interpret what the underlying causes are? How do we respond effectively? Also, how to look for delirium so we could address that quickly. We collaborated with Dr. J on simplifying the medications, getting rid of the statins and all the meds that really weren't offering any benefit, and helped Dr. J more expertly manage symptoms like pain, sleep problems, sometimes some psychotic features. We educated Rita on as much dementia-related materials as we possibly could to really empower her, help her be her best. We provided a lot of emotional support and validation because this is one of the hardest things dementia caregivers will ever do in their lives. And there's a learned helplessness and hopelessness that seems to emerge. And we really need to honor and uphold the incredible actions, of love in action that they are providing. We connected Rita with her resources because in her spare time, she was not going to have the energy or the ability to decipher what was out there for her. We also wanted to create meaningful engagement in order to focus on living. We wanted to identify the risks and all of the distress, but we also wanted to add on to it what is going to bring comfort of life, quality of life to both of these individuals. How do we keep them feeling intimate without the use of language? So finding customized, meaningful engagement for them, and we provided a volunteer. That way, Rita was able to address her own healthcare issues. Also, she took classes on ambiguous loss, which addresses this complex grief experience of dementia caregivers. And she also took my mindfulness-based stress reduction class in order to learn more effective coping skills as she moved through all of this. When we look at some of the outcomes, well, for Lou, we got all of the paperwork completed and clarified what was most important to Lou as far as who was the medical power of attorney, the advanced directives that were based on evidence. We were able to, at every fork in the road, and there were a lot of bumps in this road, we were able to say, what are the goals of care? And then to see how the options that were available would align most with his goals of care. And ultimately, Lou became calmer, happier, and comfortable. As far as Rita, she developed a whole lot of dementia-related knowledge and skills and was able to keep him in the home. We earned her trust. We were able to bring in some CNAs in order to provide personal care, which at least lifted that strain from her. And over time, she trusted us more and more with our recommendations. We were able to integrate the support service. She used that 24/7 line probably twice a day, but good for her because she didn't feel alone. And she improved her own self-care practices. We watched Lou very closely for when we would be able to admit him to hospice, and so we got him on as soon as possible. And again, we were able to bring in the richness of the interdisciplinary team, all of the extra resources, the hospital bed, et cetera, that they would need. And I'm very happy to say that Lou eventually died at home with Rita by his side. We were able to reduce the amount of behavioral expressions and polypharmacy. We weren't able to eliminate the stress and frustration, but we were able to help with that. And we reduced the calls to the PCP and to the fire departments. I'm happy to say we avoided emergency room visits and hospitalizations, and we honored their dream of him never leaving his home. Dr. J learned best practices in palliative care as we collaborated with him, because the PCPs are doing so much of this and they just don't really have the skills at this point. And in conclusion, I was just going to say that the quote from Dr. J, I'm not sure if I can get back there. Can I? Or could somebody help me? There. I just want to, Rita said they helped me be better caregivers and that it helped her learn what to do and how she used the phone and phone support and that it really helped. But here's what I want to end with this message. Dr. J said, I need eyes in the home and feet on the ground to help assess the family and then get back with me. I can do a better job if I have collaborators. These families are desperate for some sort of coherent program that can give them an idea of what to expect, what they can do now, in the future, and begin to plan for the natural progression. So on behalf of those entrusted to my care who have been my greatest teachers, thank you very much for your attention.
Thank you so much, Dr. Gallagher. Now we're going to move on to Dr. Joan Carpenter.
Well, thank you so much for inviting me to speak today about the work that my team and I have been involved with since 2015 in the Department of Veteran Affairs. It's really a delight to be here and a part of this distinguished panel of dementia care experts. The focus of the next 10 minutes or so is going to be describing a clinical innovation that we implemented in the VA, where we worked to partner staff and families to enhance advanced care planning for veterans living with dementia who are residents of VA nursing homes called community living centers. Next slide. So over 250,000 veterans are served by the U.S. Department of Veteran Affairs that have a diagnosis of dementia. And this equates to approximately a 9 to 10% dementia prevalence among VA patients. However, as we all know, the prevalence is expected to rise dramatically, and the VA projects a 20% increase. Sorry, I lost my video there for a second. The VA projects a 20% increase in the number of veterans diagnosed with dementia in the coming 10 to 15 years. So we've talked a lot about dementia today, but we know that individuals with advanced dementia are often cared for in institutional settings, such as nursing homes. And the VA owns and operates 133 nursing homes called Community Living Centers, or CLCs. And 1/3 of CLC residents have a dementia diagnosis. Dementia, as we've talked about, is a serious progressive illness characterized by a decline in function, memory, language, and decision-making ability. Therefore, efforts to ensure high-quality nursing home and CLC care must address the special needs of residents living with dementia as the disease progresses, including managing symptoms, honoring care preferences, and importantly, as we've been discussing today, assisting with treatment decision-making. Treatment decision-making for individuals with dementia is particularly challenging because of their progressive inability to communicate many of their preferences. Thus, families and healthcare teams must collaborate to make care decisions that consider the residents' personal values, their clinical situation, and their best interests. Next slide. In 2017, the Veterans Health Administration National Center for Ethics in Healthcare launched the Life Sustaining Treatment Decisions Initiative, also called the LSTDI. It's an integrated program to promote goals of care conversations and identify preferences for life-sustaining treatments for veterans with serious illness. And as I'm talking today, we're talking a little more about people living with dementia. These conversations and preferences are documented in a durable note and order set that's readily accessible across the VA healthcare system through a standardized template. The LSTDI is a multi-pronged, evidence-based program which included a very carefully planned dissemination program with national support for implementation across all VA care settings. Next slide. So our goal in the program that I'm discussing today was to extend the implementation of the Life Sustaining Treatment Decisions Initiative to community living center residents who are living with dementia by identifying their care goals and treatment preferences that direct day-to-day care decisions. Given the challenges that I talked about in determining care preferences for nursing home and CLC residents with dementia, we combined the principles of person-centered care and the LSTDI to design a clinical innovation centered on building partnerships between the community living center staff and family surrogate decision makers and the person living with dementia if they were able to be involved, to enhance care planning and life-sustaining treatment decision-making. This project, called the Partnership Program, was part of a 5-year quality improvement and implementation program that was funded from 2015 to 2020. Next slide. So to meet our project's overall goal, which is to identify goals of care that direct day-to-day care decisions and enhance quality of life, family members and the veteran, if able, were asked to identify 2 or 3 community living center staff members whom they would want to participate in meetings that were dedicated to discussing care preferences and goals of care. Staff partners could be anybody on the interdisciplinary team because we know that people who live in nursing homes and community living centers consider all of the folks in the nursing home part of their family. It could be a person who knows the veteran well, such as the nursing assistant, an activities director, a dietitian, a nurse, psychologists, chaplains, nurse practitioners, physicians, or physician assistants. In this way, the partnership program aimed to build support and trust, improve goals of care discussions, and enhance outcomes. In these meetings, the staff would work collaboratively with the veteran and their families to develop care plans to achieve 3 person-centered goals: to identify daily preferences around care and activities, to support the balance between honoring daily preferences and safety, and to introduce goals of care conversation in the context of daily care preferences. Next slide. So the first step in this program was to identify activities that the veteran enjoys. And to do this, we used a modified version of the Pleasant Events Schedule, which is the nursing home version. And this tool includes 30 activities. I have some listed here, but these are things like listening to music, sharing a meal with friends or family, attending religious services. And families could even write in activities that weren't included in the list. In our project, discussing pleasant events and daily preferences offered a natural segue to exploring broader veteran and family surrogate values and daily care priorities. Next slide. After completing the Pleasant Events schedule, our goal was to balance veteran autonomy and safety to optimize quality of life. For example, an older veteran with dementia may prefer to walk around without assistance in the CLC, which poses a risk for falls, wandering outside the facility, or entering other veterans' rooms. Determining how to maintain veteran safety while accommodating that preference through care planning, even when the activity or behavior holds a risk, was really important. Staff systematically assessed the veteran's functional abilities and engaged decision makers in discussing the potential risks and outcomes of respecting these choices, as well as the potential consequences of not following these choices. Next slide. Another goal of the program built off of the Pleasant Events schedule and the activities that were identified to introduce the goals of care conversation within the context of those activities. For instance, a family surrogate decision maker may realize that due to advanced cognitive impairment, there were very few meaningful activities beyond eating that the veteran could engage in. Therefore, limiting oral intake and instead using medically administered nutrition may not align with the pleasure gained from eating. In the partnership program, staff support surrogates to identify treatment options that consider the residents' values and preferences. Next slide. So I'm going to give you a couple examples of the partnership program in action. The first example is Mr. A, who's been a CLC resident for approximately 10 years with moderate cognitive impairment. He enjoys participating in regularly scheduled recreational events. However, when activities aren't taking place, he is frequently placed in his wheelchair near the nurse's station so that he can be monitored for safety because he's considered a risk for falls by getting up and out of the wheelchair. During the first CLC partnership meeting, the family member that was involved in the meeting expressed that she would like to see her father participate in more activities. One of them that was identified on the Pleasant Events schedule was attendance at religious activities. And while the daughter described how important spirituality was to her father and that he attended religious services at the CLC, it seemed that if there were other opportunities for him to be involved in services at the chapel at the local VA hospital, which was adjacent to the CLC, would be helpful. So the CLC social worker suggested that the staff could make arrangements for a van and a staff member to take him to the services at the acute care center adjacent to the CLC. So this example highlights that even for residents who have been at the CLC for some time, it's worth revisiting preferences for daily activities. Next slide. Another example is Mr. B, who's a CLC resident with advanced dementia and dysphagia and was prescribed a pureed diet. Despite his advanced illness and limited ability to swallow effectively, Mr. B expressed his great displeasure with his diet. Therefore, his family wanted him to receive a regular diet, and even that if that meant an increased risk of choking or aspiration. The staff were concerned, of course, because an increase in choking risk and because of the chance of an increase in choking risk in subsequent events, such as respiratory arrest. And because Mr. B's plan actually included the use of all life-sustaining treatments. And that was a treatment decision that seemed at odds with a focus on comfort and enjoyment, considering the advanced stage of dementia that he was in dysphagia. So discussion in the partnership program and meetings focused on the family members' understanding of the risks and benefits of life-sustaining treatments such as cardiopulmonary resuscitation, mechanical ventilation, and how those could impact somebody with advanced dementia. And that the recognition that allowing Mr. B to eat a regular diet may increase the risk of choking, aspiration, pneumonia, possible respiratory arrest. What happened is this line of questioning revealed the family member's belief that by changing the veteran's medical orders to a do not resuscitate would equate don't do anything for him, and that he may not get all of the care that he desired, such as antibiotics, if the family felt that that was something that met his goal of care. So as a result of the partnership meeting, the staff set up another meeting with the family and the veteran's primary care provider in the CLC to provide more information about life-sustaining treatment decisions and determine how to honor the diet choice, mitigate risk, and review alternatives. Next slide. So our next steps, and all the work I've talked about today, it's within the VA system and for veterans being cared in the VA system, but we know that many veterans are being cared for in non-VA settings. So our next project is the preferences elicited and respected for seriously ill veterans through enhanced decision making. And the goal here is to reach veterans in community nursing homes through state authorized portable orders for life-sustaining treatments, most often known as the POLST paradigm, sometimes called the MOLST. Every state has different guidelines. And the goal of this program is to increase the number of veterans in community nursing homes who engage in goals of care conversations and have their life-sustaining treatment preferences documented and honored. Next slide. And in closing, I just want to recognize this incredible team that I'm so honored to work with within the VA. Incredible dedication to improving the quality of life and the care for veterans and those living with dementia. Also, our operational partners throughout the VA and the Quality Enhancement Research Initiative who supported this project. Thank you very much.
Carpenter. Our final presenter today will be Dr. J Neal Henderson. Dr. Henderson, we look forward to hearing from you.
Thank you very much. Halito and Chima Chukma. Hello, and hope everybody's well. And I'm not able to advance the slides myself, so let me ask for the next slide. So I'm still unable to do that. Okay, thank you. The first thing we need to be able to understand when we talk about the perspectives of end-of-life matters with Indigenous people, and that is the huge range of cultural variability. Next line. There are 574 currently federally recognized Indian tribes in Alaska Native villages, and that brings with it more than 175 different languages. So we can begin to see where there is the source of this huge variety. Next slide. So to account for inter and intra-tribal heterogeneity, there is the need to accept that, the next line, there is no one way, there is no one native way of believing or behaving virtually about anything. The rule would be for people engaging with tribal populations and villages in Alaska is to make no assumptions. I think many times people have an assumption that there is an unwillingness to talk about end-of-life matters, or there's an unwillingness to deal with body donation or brain donation with regard to research on dementia. And that would be a mistake to continue with those assumptions. And I want to conclude with some ways to explore what the reality could be across individuals and families and tribes. Next slide. And the term for this in social science is cultural pluralism. And so for our topic today, we're talking about a mix of tribal and colonial beliefs. Next slide. When we're dealing with end of life, we're also talking about the cultural category of cosmology. Where are we from? Why are we here? What's going to happen next? And the majority population at this point in time in this country is Christian, and so I use that term here. And the mix of those beliefs with tribal beliefs are often things that we will encounter when talking with living people in real time. Next slide. I want to use this example as a one of the mix, and it is myself with a friend who has a relative that had recently walked on. And we were heading out to the Indian church where there is the cemetery next to it. And I was driving a pickup, and it's a remote location, so we're going kind of slow through some creek beds and things like that. And she said to me, you better hurry up, because if we get there and it's dark, I'm not getting out of this truck. That was a reflection not of her occupation in health program services. not in her college degrees, but in her traditional beliefs in which the soul of the person that's walked on can remain in that location and be out and about, particularly after the sun goes down. Next slide. Another example of how the mix of traditional and contemporary life can occur is this, and it is at a friend of mine who had walked on. So we're at his Indian church and at that graveside, and they had arranged to have 3 people sing Amazing Grace in Choctaw language. The words are actually different, but it's the same melody. The tribe had for many years produced these hymnals, which were widely distributed. And so 2 of the people were reading from the hymnal, but another one was using an iPad standing out in the woods at this Indian church. I hope these are little micro examples of how cultural flexibilities operate in real time and place. Next slide. So there are some terms maybe that are more often used. So let me ask you to just populate the slide, please, with all the lines. Okay, thanks. And the first one there may help, and that is that there is a common belief, not universal, but a very common belief that everything has a spirit of soul, whether it's animate or inanimate. And so you see these terms that involve animals at times, but please understand number 9, and that is also the conventional concepts and terms from contemporary Christianity. Next slide. Populate this slide for me too, please. This is an example of sort of the reality of sometimes the interface between the matter of traditional ways and non-Indian ways. The late playwright William Yellow wrote this piece called Sneaky, and it's about 2 brothers wanting to get their mother out of a white funeral home so they could have her undergo the culturally appropriate mortuary practices and behaviors. And so the fact that this is meaningful out in Indian country is an important piece of information. Next slide. Next slide. There is often talked about a wish for an intact body at burial. And a friend who has a number of joint replacements requested that he could have those skeletal materials that were removed. They're in his freezer. They'll be placed with him when the time is right. And the reason for this is so that the body in the other side, in the other world, which should be intact so people can do the things they need to do. Well, with dementia and end-of-life issues and wish for an intact body, we can imagine that this would really suppress brain donation. And my work has shown that there is a big depends. Yes or no, it depends. And there clearly are a large number of Native people that are willing to engage in donating their brain for Alzheimer's type research. And yet that has, I think, not been realized to this point in time. As we all know, I think the coordinating center has thousands of samples, but very, very few, on the order of 300 or so, that come from indigenous people. Next slide. One of the common things, and this comes from what I'll be presenting next, comes from my life experience, and it includes, in this case, the dying process is recognized often by the other people in the family that this person is talking to others that have gone on before them. And that means that they're talking to the ancestors, and that's important because those people are going to come get this person at the moment of death and take them back to the other side. Next slide. The relatives then sing what are called death songs. Next slide. But that may sound a bit morbid, but the content of them is welcoming the ancestors to come get the loved one to take them with them. Next slide. This is an example of from a different culture, and this is my maternal grandmother, who's an original enrollee with the Choctaw Nation, and she was dying in a nursing home bed. And my mother and her sister were there and got in bed with her, and as they said, sang her over to the other side, similar to the Southern Plains people with the ancestors coming down and having the death songs. So in a contemporary setting, in a long-term care setting, a similar kind of behavior. And they were singing Amazing Grace, but in English. Next slide. Next slide. So with this great variety across the tribal populations, how do we meet that challenge? What do we do besides make no assumptions? And I think it's a matter of communication. It's a matter of questioning. And when I say that, I have the word there sincerely, seek information, because I think Native people are a little jaundiced about curiosity seekers. And so a person that is sincere, respectful, that can easily be discerned versus just trying to mine some kind of what is perceived as quaint behavior or beliefs. Next slide. And one way of voicing this would be to just simply ask this: can you help me understand your ways of believing, in a way that your sincerity is shows in your voice. Next slide. Another one is, would you teach me some of your beliefs? Have the family or the elder or whoever you may be talking with be the teacher. And I have some in italics just because you may encounter people that don't want to talk about the entire complexity of their cosmology. But nonetheless, any amount of information could be helpful. Next slide. It's probably very appropriate to ask if there's a traditional healer or an elder, meaning elder status. The elder might be 40 years old, but still an elder status, that they may want to have contacted to come be a part of this process. So what we said here is there's a huge amount of variety about end of life and end of life with dementia and issues of bodies being intact at burial. And what it boils down to, I think, is collaboration, a sense of collaboration on the part of the clinician or the program planner or the hospital administrator to collaborate with the person, with the family, in a way that they actually engage with them. And when that is done in a sincere, respectful way, I think a huge amount of process and progress can be accomplished. So those are the comments I wanted to say. So you're okay? Thank you.
Thank you very much, Dr. Henderson. I just want to take a minute to say thank you to each of our partners and presenters for sharing their expertise with us. For reference, we are recording this so that the recording will be made available on the Focus on Aging webpage. If you don't have the link, all you have to do is Google Focus on Aging and that will come up. So now we're going to spend a little bit of time. We have some time left that we can take some questions that and have our esteemed panelists respond to them. The first question, just because it's just building on the talk Dr. Henderson just gave, and I'm presenting this to our entire group. The first question is, can you please discuss end-of-life care for marginalized groups, including racial, ethnic, cultural, as well as LGBTQ, religious minorities in the United States?
Since you just mentioned me, Aaron, I think this concept of communication and collaboration is very important across the board in dealing with all people, anywhere and any time. And the component of sincerity and respect is the critical part of it. I think that that also conveys a sense of valuing of that person, and by extension, maybe that population segment. And I think it's not necessary that we remember a trait that maybe all Dene people do it this way, and all Latino people do it this way. You don't have to do that. It's individualize it by asking the kinds of questions we mentioned earlier.
Thank you, Dr. Henderson. Does anybody else have any thoughts on this topic? Okay. Another question that we received was in relation to advanced directives. Could you please discuss advanced directive completion before and after diagnosis? From your own experience, do end-of-life wishes change based on when the advanced directive was completed?
I might weigh in just a little bit and say what I've observed is some people complete advanced directives when they still have most of their health, and that I'm a one-trick pony. All I do is dementia all the time. But what I see is when people are diagnosed with dementia and they start to deeply understand what is involved here and how it's going to play out, they fortunately, with good guidance and support, will change some of their decisions because it's in that context now of having a terminal neurodegenerative condition.
I have a comment too, in addition to Dr. Gallagher's. I think that this is really, the emphasis here is on ongoing discussions, on, having that conversation after hospitalization, after an acute change in condition, after a significant weight loss, about what the preferences for care are and what the goals of care are. And I think when you refer back to a document that was developed 10 years ago, it's very challenging. I always tell the families I work with and the residents with dementia that I work with, if they're able to appoint a decision maker, I'm more, that's where I want them to focus, is who would be making their decisions when they can no longer make their decisions for themselves, and giving some ideas around what their preferences for care are, but making sure the person who's making the decision has a clear idea of what that person living with dementia wants and doesn't want.
Thank you. Any other thoughts before I go on? So we've sort of touched on this all along throughout for our time together. Does anyone have any specific or non-specific guidance on how one can bring up the topic of end-of-life care with caregivers?
I can take a stab on that one. I think that I think you have to give people opportunity and do it as upstream as possible. And most people will only talk about what they want to talk about, but I think you have to open the door for them and just say, we know quite a bit about what to expect as your loved one with dementia progresses in this illness, and what would you like to know? And sort of open the door and offer people the opportunity to learn about it. And from giving many talks and talking to a lot of people, even though there's this worry that people will be reticent or it'll be depressing or something like that. In fact, most people really do want to talk about it and want to learn about it. And they'll tell you when they won't. But I think it behooves us as providers to provide the open door and the opportunity.
I'll also add that I have a colleague at the University of Rochester, Dr. Robert Holloway, who says that almost everybody who gets diagnosed with a serious medical condition has two questions in his or her head. It's really how well and how long. How well am I going to live with this, and how long am I going to live with this? And so, as we just heard, many people are already thinking about some of these end-of-life issues, but they're waiting for somebody else to bring it up. And so what I try to do is normalize the discussion. I say to people, I want to make sure that we're taking the best possible care of you from the time of diagnosis all the way through the disease to the end of life. And one of those things is really ensuring that we know who you would want to help you make medical decisions and what kind of medical decisions you would want at end of life. And sometimes people kind of look at me and I say, I have my paperwork done because anything could happen to me. I could be driving home tonight, get hit by a car and end up in the ICU. I don't want them guessing about what to do. I want them to know who to call, and I want that person to know what my wishes are. I mean, that's a gift that I've given my family. I told them my wishes. So they're not making decisions on my behalf. They're honoring my wishes. And so people kind of nod and they get that. And we talked some about when people get a driver's license at 16, they put on there about organ donation. Organ donation means you've already died. The conversation I want to have with you is, what do you want leading up to that? So it's sometimes easier for people to think about what I want done with my body, cremation or burial. People are much more comfortable talking about what happens after the death. And we're trying to normalize the conversation for what happens during life before you die.
Great answer. Thank you.
Let me add on to that. That you just triggered this kind of thought or a dichotomy that often is present when talking about marginalized populations. And it's always a kind of a negative view as opposed to an asset view. And I think here we're talking about essentially sharing with families that there are things to do, things that will be done, preparations that will be, knowledge that you can be given. And that is more of an asset kind of approach, I think, that would be helpful along with the just the facts of the matter.
Anything else from anyone? Thank you all very much. That was great. Sort of taking on that, what Dr. Robinson was talking about of what to do while you're living. We had a question regarding asking for guidance for community frontline providers. How do they, what criteria would they use to advise caregivers to explore hospice as an option?
So I'll start with that. I just want to clarify what the question is: when to consider hospice as an option, or when to start thinking about learning about hospice services.
The question was, what criteria do community frontline providers consider when they're advising caregivers that hospice might be an option worth considering?
Mm-hmm. So the tough thing with hospice, and within the VA system, it's a little bit different, but in community, as opposed to community services. But so the guidelines for eligibility for hospice are quite advanced and very advanced dementia. And so I tend to introduce families to the concept of hospice a little bit earlier, before the person living with dementia is dependent in all activities of daily living. Whenever we see a weight loss, or we see some feeding intolerance, or we see recurrent infections or recurrent hospitalizations, I bring up the idea of hospice and hospice care and care that can be delivered in the home, wherever the home is, to start opening the door to the conversation about care as disease progresses. And I think this goes back to what we've been talking about, is having this dialogue and a discussion about the progression of dementia, and making sure that surrogate decision makers understand what the role is as the surrogate decision maker is, and the clinical course of dementia, as Dr. Mitchell talked about.
And I think it's important. I don't know if the person was really asking the question about hospice per se or palliative care per se, as Dr. Robinson was talking about. Hospice, of course, is the medical benefit with this pretty narrow eligibility criteria, which is very hard to predict, of a 6-month prognosis. And so, in my view, a person with dementia should have access to high quality palliative care, whether they've got 2 months to live or 3 years to live. And so the question about the frontline providers, maybe want to start with when is it appropriate to start talking about palliative care, and then sort of lead into hospice more when someone looks, as best you can tell, really approaching the end stage. Not the day before, but again, it's hard to predict, but the later stages I described in my talk.
I think I would just also add to have conversations with the community about, we know that people with dementia are at such high risk for falls or falling out of bed. So they're at such high risk for significant fractures, and that this is something that certainly seems to happen quite a bit, and that they don't necessarily have to go to the emergency room and have surgery, although that's some of the messages that sometimes people receive.
Great. Thank you all so much. I did have another question on, I think it was Dr. Carpenter that talked about the pulse. A question on, please comment on the effectiveness of physician orders for life-sustaining treatment. Does anybody have any thoughts on that?
I'll start off real quick. Just that the most important thing is that the paperwork is with you. So that's where in the VA, because this is available throughout all VA settings, we've been quite fortunate. Home-based primary care, community or VA nursing homes, and acute care settings as well. So I don't do as much work with the pulse paradigm. I'll let some other folks comment on that.
Anyone else have any thoughts on that?
So what I'll say is that POST forms, the physician orders for life-sustaining treatment, or MOST forms, medical orders for life-sustaining treatment, are under that advanced care planning umbrella, similar to living wills and healthcare surrogates, collectively termed sort of advanced directives. The difference is that the living will and advanced directives are legal documents, and POST and MOST forms are medical documents, because the physician is part of that sort of decision making and present when those are completed. And the POST and MOST forms, I tend to tell people, are more about sort of the here and now. Given what's going on, what kind of medical care do you want? And many times we think about the living wills as in the future. If or when you get to the end of life, what kinds of medical decisions would you want? And somebody, I think, asked a similar question at the beginning about, do people's views change? And sometimes the MOST and POST forms can be more helpful, particularly when people are kind of in that setting versus completing it at age 30 or 40 in anticipation of at some point I'm going to be nearing the end of life.
Yeah, I'll also add that the MOST or POST, they're effectively documentation of an advanced directive, or, do you want resuscitation? Do you want to go to the hospital? Do you want to have antibiotics, et cetera, in some states? So it's a pretty narrow document. Granted, it is meant to be transitional across different healthcare settings, but I think an important message is that form is only good as the conversation that was had to fill it out, and the counseling that went around, helping people reach their decisions and articulating that around their preferences and goals of care. So I think you really have to have the two, and especially an effective and compassionate conversation that informs the completion of those forms.
Thank you so much.
One other thing here, and it comes from Zuni Pueblo. This has been published, and it has to do with this communication about how to approach this business of hospice or end of life in general. And one of the things that was found helpful there was to ask a person, if this happened to someone else, how do you think it should be handled? And that allows a kind of distancing at the beginning of the conversation to have the person maybe not put up their own unconscious defenses and not be able to be very effective in responding, but then you can bring it back around. And this is a publication that's just a few years old, And the report from Zuni and Dr. Eric Peterson is that about 90% of the clients there have now filled out advanced directives. So this is another example of where assumptions about the reluctance of Native people to engage in these kinds of conversations or legalized forms can be put together and moved ahead, but in a collaborative fashion.
Thank you so much. That's an astonishing number there at Zuni. I think we have time for one more question, and it's not sure if this is in your wheelhouse or not, but is there standardization in determining when a person living with dementia is no longer deemed capable of making sound decisions with regard to end-of-life care?
I mean, there's pretty standard components that are considered when a person with dementia is considered about their decision-making capability for whatever decision, whether it's about end-of-life care or medical treatment. They have to understand the situation. They have to understand their choices. They have to have a sort of reasonably rational way of arriving at their decision. May not be what you and I would want, but something that makes sense. And so geriatricians, palliative care providers, psychiatrists are skilled at assessing whether someone has decision-making capability using that rough rubric. Of course, it's not often a black and white thing, and a person may have decision-making ability to make decision A, but not so much for decision B. They might not be able to make a decision about their bank account, but they may be able to articulate a decision of whether they want to have a foot amputation or something like that. So usually you take it decision by decision, and then there's legal standards as well for determining whether a guardianship or a healthcare proxy is invoked.
Thank you. So we have 4 minutes left, and I have one more question that I'm going to read to you because it's kind of complex. If you have the answers, that would be great. Palliative care is for any age, any stage, but it seems to get lumped into end-of-life care, which clients tell me is not engaging language to start compassionate conversation. Is any consideration being given to engaging certain communities with other words, especially since many want to hear about other care options besides that include curative care options instead of guiding the conversation to end-of-life care? I know it was a sort of multi-pronged question, loaded a little bit.
I can maybe start. I think I understand what the question's asking. What I would say is that oftentimes I think people are confusing the terms palliative care and hospice care, or palliative care and end-of-life care. So I think the first distinction that needs to be made is that palliative care, as you started the question with, is appropriate at any age and any stage. Palliative care has nothing to do with whether or not you have a terminal condition or if you just have a serious condition that is curable. Palliative care is really just to focus on improving people's quality of life. People have termed it also supportive care. I mean, everybody says, I can use a little support. Sometimes it's a more palatable term, not only for our patients and caregivers, but also sometimes for our colleagues as well, to send people. And so actually my clinic is termed a neuro-supportive care clinic. But I think that's the first thing I would emphasize, is that palliative care has nothing to do with life expectancy or the nature of the condition, about whether it's terminal or not. And I think when we talk about palliative care, we're talking about kind of this comprehensive model of care with nurses, physicians, social workers, sometimes there are therapists that are part of the team, and spiritual advisors, etc. And so it is really an opportunity for people to get more support than just from a physician as well. But I'll tell you that palliative teams also focus on support in general, like caregiver support or other resources in the community. And so I think it goes beyond just thinking about the medical resources to what the needs are for the specific person and family members. That's really the role of palliative care teams, is to figure out for a person specific or individual specific basis what sorts of needs and resources are available.
Yeah, I would just
Great.
build, my direct experience was that we called it the Palliative Care for Dementia program in 2013, and I kept trying to educate people of what palliative really was. And then finally, it was just this year that I finally succumbed to changing it to the word support, knowing that who doesn't want support?
Exactly. Thank you so much for fitting that last question in. It was a great way, ending on a high note, sort of recapping what we've talked about here for the last hour and a half. We just want to thank everyone, our panelists, for their amazing presentations, and also for everybody who joined us today. We hope that you got what you were looking for out of this discussion, and we just thank you so much. I hope everyone has a great afternoon wherever you are, or evening, and we will hopefully, our paths will cross again. Be well.